All right, well, good morning. And thank you all so much for coming out here this morning. It's great to see so many people interested in this really important topic of kidney health. I'm Kate Warren, Executive Vice President, Executive Editor at Devex, and we are delighted to be partnering with ISN on this event this morning on the sidelines of UNGA, and as we are looking ahead at the high-level meeting on NCDs. Kidney disease is a topic that often doesn't get the attention it deserves, given that it affects over 10% of the people worldwide and is on track to becoming the 5th leading cause of premature death by 2050. Yet it's still missing from a lot of NCD strategies, and with it being tightly linked to diabetes, hypertension, heart disease, it really needs to be part of the broader conversation. So that's what we'll be doing today. Momentum has really been coming behind kidney disease. The recently adopted first ever WHO resolution on kidney health really recognizes kidney disease as a priority in addressing NCDs. But now it's really about implementation and how we put that into action. And that's what we're really going to focus on over the next hour in this conversation. And I am delighted to be welcomed by Dr. Marcello Tonelli, who is the the president of ISN, and our co-host for today. So, Marcello, thank you so much, and I'd love to just hear kind of your thoughts as we head into this next hour of conversation.
Well, thanks, Kate, for the introduction. It looks like it's going to be a great session. We have some excellent speakers. It's a really exciting time to be a kidney health professional. With the resolution, the momentum, the political declaration, we're really looking forward to learning from our colleagues and especially trying to learn on how to capitalize on the success that we've seen with the diabetes stakeholders dating back to their resolution in 2006. Looking forward to a really exciting panel.
Great. Well, we are going to first start out with a discussion here. So we'll sit down and grab a chair and then invite Professor Peter Schwarz to come to the stage. And we will get a microphone for you as well. And Professor Peter Schwarz is the president from the International Diabetes Federation. So, as I think we all know, the close link between diabetes and kidney disease. So really happy to get his perspective here. So thank you, Peter, for joining us.
Thank you very much for being here. It's a great honor to be in this panel.
Yeah, with all your kidney friends here in the room. So I want to talk a little bit about this WHO resolution on kidney health and how closely kidney disease links to diabetes, and what opportunities you see in that interconnectedness to really elevate kidney disease under the broader NCD agenda.
Yeah, in general, I must say the declaration which will come out, we are a little bit frustrated about what is written in. We looked at the zero draft document 4 months ago in Geneva, and actually we were excited because there was so much diabetes in complication, kidney health was included. So we said, okay, this is a very good start. What we are getting now is diluted and diluted and diluted again. I understand that sometimes politicians want to take all the cracks and not make responsible for something. So this is the one heart in my breast saying, okay, it's very, very light. On the other hand, we can use it. Everything what is important is mentioned. Especially for kidney health is mentioned. Many other aspects were lost on this way. So this is a big opportunity to, I apologize for saying it this way, to use the kidney as highlight how important it is to translate our knowledge, our vision, our policy into action. And we attended yesterday, I stopped counting, maybe 15 meetings and so on, and it was always the same, we have to translate it into action. The people who sign the declaration don't do the action. So this is our task. So we have to think about how we can use the declaration as a kind of anchor or horse to convince our own politician, our own stakeholder, our own partners to increase the probability really to start action. And this is what I will take home, also for the diabetes side. And I would like to end with a short story. As president of IDF, I have the chance to travel to many countries, and I always meet with a member organization. I always ask them what is their need. And I was on a very small, tiny Caribbean island, and they hate insulin. Even the physician, the patient, and they said, no, you cannot give insulin, it's from the devil. it was this region with the highest prevalence of kidney health in people living with diabetes. It's not evidence, it's personal experience, but it's from our blood sugar brain-driven interest. You have to normalize blood sugar to prevent complication. And you have to start earlier to normalize fatty liver disease to be better to normalize blood sugar to prevent the complication. So the dermatologists have a nice meaning. They say the psoriatic marsh. And for us, it's also a kind of marsh starting from liver fat, insulin resistance, hyperglycemia, metabolic syndrome, and then the complication. And the kidney at the end kills our patients, and we can prevent this.
Yeah, and so you bring up the point of this is a lot of conversations around how you take this piece of paper into action. And so Marcello, I would love to hear kind of your thoughts on the piece of paper or a declaration. It's a great start. You want that, right? But really it comes down to how you implement it. And I think you gave a great example of the challenges of doing that on the ground. So Marcello, what do you think that countries should be doing as far as kind of first steps to really take this and implement it into action?
Well, first of all, I'd just like to respond to what Peter said. You know, it's fantastic to have IDF here. We've been a tremendous fan of what your community has accomplished over these last 20 years. Really, you've, I think, shown the playbook. I think that I'd say two things. The first, before I get to your question, the first is that I'm a glass half full kind of a person. So yes, what is in the resolution and in the commitments of the high-level declaration, you know, perhaps they could be more specific. Perhaps there could be fewer of them. From our side, what we like what we see. We see kidney disease identified as a major threat to health and life. We see a specific call to build kidney deliverables, drugs and diagnostics, into KPIs that countries need to meet. And we see, most importantly, I think for this meeting today, acknowledgement of the tight link between diabetes and kidney disease. We know that as many as 2/3 of patients with diabetes will develop some kidney dysfunction over their lifetime. We know that almost 2/3 of patients in dialysis programs have diabetes. There's a natural synergy there. So those are, I see opportunity. And I think the second thing is that you in diabetes have shown us, dating back to the UN General Assembly in 2006, a playbook for how to take commitments and turn them into action. Now, it took 20 years to get where we are today. It's going to be a long game, but you've shown optimism. So to your question, I think it's tempting as healthcare providers to dive right in and start taking drugs and treating patients. That's what we are trained to do, and that needs to be done. But what I take away from the diabetes experience is that some preparatory work is needed to sustain the success over the 2 decades or more that it's going to take to drive action. So I think about things like identifying a focal point in government ministries, someone that's going to be responsible for kidney disease, transcend political cycles and be able to act. I think about standing up a national steering committee that includes expertise within the clinical realm, but also colleagues like yourself and from heart disease and the other stakeholders. Should include patient representation, and not just the health ministry, but the other ministries that are going to drive commitments in government like treasury, social benefits, and so on. With that steering committee in place, countries need to take stock and they need to be honest. What is the status quo, the capacity for service delivery? Where are the gaps? Where are the quick wins? And what are the priorities for countries? So those 3 things, they sound like, what are you doing? You're just delaying. But I think those things are important. With those things in place, that's when you can get a plan that has a budget line item. That's when you can get concrete deliverables and KPIs. And that's when you can get the commitment of time, resources that are going to make a difference.
Okay.
If I'm allowed to add something, if you look into the declaration, from the eye of the kidney health, there is a red line through the declaration, which is excellent in focusing on kidney health. I know that there are many other organizations who are a little bit frustrated and say, we also want it for our liver or blood pressure or dementia and cancer, a red line. What we should avoid now is that the others are frustrated and you run through the declaration. We should help each other in using the kidney as an anchor for actions to prevent diabetes, maybe to lead to diabetes remission, to prevent obesity, to prevent fatty liver disease, and so all the precursors or the roots where at the end also kidney disease is coming from. And you just made me very proud with the 2006 mentioning the United Nations Declaration on Unite for Diabetes on diabetes. This was a big effort with a lot of partners. And finally, we have the blue circle, our sign representing the United for Diabetes Declaration. And today, and maybe we can take this as an occasion, 23rd of September. Today, it's our 75th anniversary. It's our birthday, if you want, today. And some people say, oh, a pretty old organization. No, we are an experienced organization. And let's use this experience and join our forces, not saying we have won and the others have lost with the red line, but work together to finally use the kidney as an anchor to improve overall quality of care, NCD care for our patients.
Yeah, well said. And you may come to regret these words because there's a lot of work to do and we're going to be leaning on you very heavily. Thanks a lot.
But the arms of IDF are very wide open and 130% support for this. And we are ready to not only to talk together, we are ready to walk together.
Great. And so what are you hoping to see coming out of this week and this high-level meeting on NCDs that you think can either further kidney health as an anchor or as mutually beneficial in the other NCD work that's happening?
Yeah, it's again the two hearts in my breast. If I'm looking from the diabetes side, we would have wished to have more times mentioned in the final document, because in the zero draft it was pretty good. Also differences type 2 diabetes, type 1 diabetes. There is a big exploding burden related to diabetes worldwide, but it's especially Southeast Asia and Africa. So if we really want to have an impact, I apologize for what I'm saying. It doesn't matter what we are doing in Europe and North America. It matters what we do in Southeast Asia and Africa. So this is where our focus should be from the diabetes point of view. From the kidney point of view, I don't want to repeat what I just have said. I see a very good chance. If a disease has a red line in the declaration, then we have to translate it into action. For us, 2006, it was a big win, and we were so proud to have this declaration. And then we start thinking, now, what is coming now? Yeah, and then it's not the United Nations doing the action. Yeah? So we have to work with all the member organizations, with our partners. Like you have said, you named all the partners. And then in every environment, think about what would be the right approach. And the approach is maybe different in Sri Lanka or Myanmar or Finland. And this takes the same as effort. Probably it takes much more effort to build this up. So how to measure the quality of kidney care everywhere in the world, how to identify barriers, how to develop policies to address these barriers, what are the right stakeholders. And I think there is a big, but very satisfying work ahead.
So, kidney health is very complex and very expensive, but if you can get on the prevention side, and obviously diabetes, if you can get that under control and cut down the chances of developing kidney disease, in the long run, you can save money. Marcello, how are you thinking about making the case for investments, and when you're thinking about the country level in prevention as a overall tool for addressing kidney health, but also from a diabetes lens?
Yeah, I actually find it pretty straightforward and simple case. We know that kidney disease is common. We know it's deadly. We know it's very costly, devastating for families. But the good news is that it's straightforward to detect and straightforward to treat in primary care if you provide people with the right tools and the right support. We know that every dollar spent on prevention of kidney disease and prevention of kidney failure translates up to $45 in averted downstream costs. So, if someone offered you the chance to invest in a stock that was going to have a 45-fold return on investment, wouldn't you be lining up to buy shares? And that's the value proposition that we need to keep putting in front of countries. You provide simple diagnostics, you provide simple relatively inexpensive drugs. You support primary care practitioners in how to use them. And you know, we have the diabetes playbook, but we have another advantage. We have another 20 years has passed, and we have mHealth tools, we have simple tech. It's going to be a lot easier for us to support primary care practitioners to use those drugs and devices. You can imagine point of care algorithms, simple apps that tell people when to test, what to do with the results, who to refer, how to refer. So these are the tasks that we need to accomplish together. And I will say, you know, prevention and early detection, they are the highest priority, clearly. We first need to treat the patients that we already know about. That's the very highest priority, because we're not doing that as well as we should. We do need to find the new patients, and especially those that have other NCDs like diabetes, so that we can have integrated programs instead of new siloed programs. But we also, where that makes sense, we need to expand access to kidney replacement therapy like dialysis and transplantation. We know that at least 1 million people and maybe more die every year because they don't have access to that. This is not going to happen overnight, but we do need to start that. And I would argue that health technology assessment is an underutilized tool that we should be using more to guide those tough decisions about who to treat, when to treat, how to treat them, and how to make those difficult choices.
What we have experienced in the last 20 years, where Africa and Southeast Asia, the prevalence of diabetes is increasing, that physicians working in Congo also, they come and say, yeah, oh, we see more and more diabetes patients coming, primary healthcare. Yeah, what should I do? I never was well trained about diabetes. So, as you were talking about primary healthcare, everyone here in this week talks about implementing new actions in primary healthcare, but we have to educate the healthcare professionals. So finding a way, we do it with the IDF School of Diabetes, finding a way, maybe for free, to educate them about kidney health, about kidney prevention. The second step is, if you have the patient, what is this patient education? And I think you are totally on the right track using digital media. We are very open also to AI to be used for lifestyle intervention for people living with diabetes. We could use the same for kidney health. But important is also talking to the policymakers. In general, they are always positive. They want to do something. But they will not develop the concept. So we have to have easy to read and easy to implement concept to improve kidney health. So measuring the quality of kidney health in every country in the world, and then coming back with proposals how to improve the situation could be a model. This is what we try since 20 years, but it's also 20 years. So it's 20 years acting on this level. And I actually wish you very good luck to achieve it in 5 years with the kidney health.
Well, thanks. And as I said, we've had a good blueprint to follow. And a couple of times you've mentioned about the whole world. And I think, you know, this is what makes the task look unmanageable. But it's not unmanageable. You've shown us that if you break the task down into small parts, you can get it done. And you don't have to teach every country individually. You can do it at regional level, as IDF did with regional workshops, where regions share best practices on how to get things done. We don't have to invent the wheel in 170 or 210 jurisdictions. We can do it a few times. We can learn from leaders like Guatemala, like the other Latin American countries. We can learn from Thailand. There are many countries to learn from, and we just have to figure out how to best do that.
And I think we're going to learn from some of those examples in our next panel. So Peter, Marcello, thank you so much for helping to set the scene. And we will move on to our panel conversation, but thank you both. So we got a full stage up here. So I'm really delighted to welcome our panel onto this stage. We have Nick Banatvala, who is the head of the Secretariat at the UNITF, which is the UN Interagency Task Force on NCDs. Nick, thank you for joining us. We have Dr. Cressida Habunjard, who's the Director of Division of the Non-Communicable Diseases in the Department of Disease Control, the Ministry of Public Health in Thailand. And we have Richard Knight, ISN, Patient Liaison Advisory Group for North America and Caribbean region. Dr. Randa Seeley Thomas, who is the Assistant Director at PAHO. And Dr. Guled Abdijalil Sheikh Ali, Director General, the Federal Ministry of Health in Somalia. So thank you all, and I'm delighted we have such a rich variety of perspectives here for this discussion. And you know, we started out in the earlier one talking about how we can take these resolutions and these plans and put them into action, into implementation. And Nick, I'd love to start with you. So this UN task force is really looking to help turn these NCD commitments, you know, into concrete action. And so, you know, how are you supporting countries and stakeholders in doing this? And then particularly when you're thinking about it through a kidney health lens?
Yeah, thanks very much. It's a pleasure to be here. So the UN NCD task force was established back in 2013, so that's a while back now. And its aim was to bring together the UN system to support governments in the way they scale up action on non-communicable diseases and mental health. And why is that important? Because much of what we discuss and the underlying determinants, the commercial, the social, economic determinants, are outside the health sector. We've heard a little bit about diabetes this morning. If we think about what underlying the cause of diabetes and hypertension, and inevitably feeding over into kidney disease, that requires people to act beyond the health sector. Yes, we can talk to ministries of health, but when you come to talk about issues around tobacco control, about unhealthy diets, about physical inactivity, about harmful use of alcohol, then there are many other agencies and parts of government that are responsible, and also parliamentarians. So if you just think about the UN Development Programme and their involvement in development, UNICEF, because you've got to educate children, have a nice environment for children to grow up with, whether it's ITU, and we're hearing earlier today about the importance of new apps and technologies and reaching people through the International Telecommunications Union. So what we can do is we can provide through our country teams that are out there, in countries, support, working not only just with health, but with heads of state, with first ladies, or their equivalents with men, whatever, but also engaging with civil society and bringing them together. We can undertake joint programming missions to kick up the dust and to create a bit of noise on this. We can also undertake economic analysis. You were talking earlier about the economics of this. We have undertaken a number of economic analysis. We can advocate for this, working with ministries of finance, governments, and trying to promote accountability.
Amazing. And so, Dr. Chris, I'd like to bring you in because we talked about Thailand as an example in the previous discussion. We also talked about some of the challenges around just awareness and patient awareness around kidney health and the need for more education. Could you talk a little bit about some of the work you're doing to raise awareness around kidney health and some of the partnerships that you're exploring to do that?
Yeah, okay, thank you. Because we know that awareness in Thailand is not enough to prevent kidney health. So we developed like a decade, 10-year plans of the decade of the chronic kidney disease prevention that refer to the national initiative that collaboration, many organizations to work together with the integrated care models, community involvement, and strengthen primary health care network, right? We developed this plan since 2022, 3 years ago, and now we tried. This program is involve collaboration between the government authority, healthcare worker, village health volunteer. That is a major strength of the Thai healthcare system, and academic institutes like Chiang Mai University, Khon Kaen University, to collaborate, to work together to increase awareness for the people. And village health volunteers are trained and empower them to educate community and their neighbor to educate the people in their community to know how to prevent kidney disease, such like to prevent the unnecessary NSAIDs injection, or like a screening, which one who have to screen to prevent the kidney disease, such like a diabetes patient, hypertensive patient. That's the first target that we have to educate them. Yes.
And Richard, I'd love to bring you in, and someone with lived experience and bringing that perspective. And what kind of systemic changes would you like to see to really improve patient outcomes and just equity and access to kidney care? And then maybe if you can reflect on the differences between high resource and low resource settings.
Thank you for the question. First of all, I'd like to say what we're doing here today is an important step for that. The fact that I am here speaking as a patient is one of the things that we can and that we are doing. I applaud ISN for creating the Patient Liaison Advisory Group, and in that forum, we're able to talk with patients from around the world in different regions. And the role and the activities that I do with the American Association of Kidney Patients, we have a global effort. And building on what some of the gentlemen talked about earlier, education, collaboration. Less than 10%, or only 10% of the population is aware that they have chronic kidney disease. We know the causes. We know all of this. We know diabetes is the #1 cause, followed by hypertension, high blood pressure. That's how I lost my kidneys, due to high blood pressure. But what we need is we need more action, and action specifically, we must involve patients more. We talk about education, and we spend the resources. In many instances, we spend the resources in the wrong places. We need to educate patients. We also need to educate healthcare providers. In the United States, we get referred to a nephrologist from a primary care physician at CKD4. You're down there on dialysis. It simply doesn't make sense. I use other terms, but I'm in nice company here, so I won't do that. So we have to be more creative and more aggressive about that. Now we're in a position where not only can we stop the progress, but we can prevent kidney disease. We've known about diabetes for decades, and you go to the doctor and they tell you, well, you need to watch your diet, you need to exercise. Okay. But we really don't explain why. We don't explain how we can prevent it. I crashed into dialysis. Emergency room, hey, Rich, your kidneys don't work. And I had been under the care of a primary care physician. And I want to say this is a very difficult disease to manage. Most patients, particularly those of color that have diabetes, you're going to progress to kidney disease if it's unattended. So first and foremost, I think that we have to do a better job. And I think that many of the countries have the primary care physicians, but we have to get them to identify this disease earlier. Educate the patient, because you can't slow the progress if the patient isn't educated. So I think that that's critical right there. And then we need collaboration. I'm going to tell you right now, the collaboration that we have among the Patient Liaison Advisory Group is tremendous. We're exchanging ideas. We're talking about remedies. Through the American Association of Kidney Patients, we work globally and help others create patient organizations so that we can deal effectively with my dear friends, the politicians, who have control of the resources. We can do so much better, but we have to prioritize it. I commend the World Health Organization for recognizing kidney disease for what it has been for such a long time, and hope that will spur some action. I don't mean to be facetious, not talk, but action, specific policies that will impact. And I just think that we can do better. And I think that as patients, we must do better. We must engage those who are in control of the resources. We must talk with them about spending them in a manner that's going to allow us to participate and do what we can for ourselves. And I'll be very honest also, some patients, they don't like to use the term compliance, I'll say adherence. You have to do what the doctors say for your own good, because I've seen too many from diabetes. You guys are healthcare professionals here, lose different parts of the body and let it progress. And I'm just saying, you're in control of this. I don't care if your parents had it. I don't care if your grandparents had it. You can do something about it yourself.
Thank you. And Rhonda, I'd love to bring you into Richard's point around really integrating into primary health care. And learn what PAHO is doing and how you see the role of multilaterals in helping countries integrate kidney health into their overall primary health care approach or overall NCD approach, and maybe some examples of some of the ways you're doing that.
Thank you. Good morning, and I really appreciate the opportunity to be here. Just to say that PAHO was established in 1902, basically to deal with communicable diseases. And over the years, since we've seen the the transition from communicable diseases to non-communicable diseases like diabetes and hypertension, we've shifted our focus. And over the last few years, a priority for us has been NCDs, and we have a program in PAHO called the Better Care for NCDs initiative. And under that initiative, we look at diabetes, hypertension, cancer, and chronic respiratory disease. And what we do is we assist countries from the highest level in facilitating, for example, in Barbados, a national NCD commission. We facilitate the integration of diabetes and hypertension care in primary health care. We assist countries in procuring medicines for diabetes and hypertension. We facilitate health promotion, and of course, we provide surveillance for NCDs. As an example, for hypertension, we have adapted the WHO Global Hearts model in Latin America and the Caribbean into hearts. And as an example, we provide assistance, technical assistance to countries in hearts to control high blood pressure. So for example, we give technical assistance, we assist countries with clinical pathways and algorithms in order to control hypertension. In addition to that, we help them procure machines to monitor blood pressure. Not only procure, but also we train healthcare providers, nurses, doctors, physicians, assistants in how they actually monitor high blood pressure. Can you imagine a patient going to a clinic? They have a machine that can actually measure the high blood pressure, but the person who's doing it is not properly trained. And through our virtual campus for public health, we are able to reach millions of healthcare providers and train them in hypertension care. We also facilitate the procurement of medicines for high blood pressure and diabetes through our pool procurement mechanism, the PAHO revolving funds. So the HEARTS initiative that looks specifically at hypertension, we have implemented it in over 70 countries, and we've reached millions of people to control their high blood pressure. So under the broad umbrella of the NCD initiative, Better Care for NCDs, we do control indirectly kidney disease through diabetes care, because we do the same thing for diabetes that we do through the HEARTS program. We indirectly assist patients in monitoring and preventing kidney disease.
Thank you. And Dr. Guled, I'd love to get your and country perspectives if we're talking about how do we take these commitments and resolutions, put them into action. And could you share maybe some of the challenges you face in being able to really integrate kidney health into your overall health agenda?
Thank you. Good morning. First, I want to thank Devex and ISN for convening this conversation on the kidney health. For me, this is an excellent and critically important question. For a country which is a fragile setting country like Somalia, integrating on the NCD care, especially kidney health, into national agenda is quite challenging, because there is overcompeting acute health priorities, where you are combating infectious disease outbreaks and chronic malnutrition, or for example, Somalia is one of the highest maternal and child mortality rates. So if the competing priorities of the country is such acute priorities, I think it's not easy to integrate to the secondary care or the NCD care into the priorities. But for us, as a country, we have developed what we have called the National Essential Package of Health Services, which we have included in the NCD care, especially in the kidney. But as a country like Somalia, which is donor dependent on the health sector and always compliant to the donor driven agenda, and mostly focus on these competing priorities, especially the acute priorities like the infectious disease and outbreaks like the polio or measles, out corona, and especially the COVID-19, which sucked most of the attention and the resource where the donor has been provided. It was not easy for us to integrate into the national agenda. But as a government, especially where the fragile, the health system is fragile, which is lacks the critical infrastructure, shortage of a health workforce, and the shortage of the supply chains, and the capacity of diagnostic care is limited. All these we have managed to overcome mainly and integrate into the essential package of the health services. In the NCD care, although is still dependent on out of the bucket expenditure of the patient, where there is no still financial protection or the prohibitive cost of the patients. And again, also lack of the or limited data is also a challenge to integrate into the national priorities, because if you don't have well captured data that indicates the pattern and the problem of the NCD, especially the kidney health, it's not easy to integrate into the national agenda. But all these challenges we have managed to integrate into. Thank you.
Thank you. And I know we are going to open up to some audience Q&A and have a couple interventions, so I just want to make sure we have a microphone ready for that in a moment here. But just quickly, I would love to hear from each of you. It's a challenging moment right now. Countries are under stress, and their healthcare systems are under stress, and making the case for prioritizing financing any issue can be, it's a challenging moment for that. So I would love to hear each of you maybe make your quick pitch case for why countries should be prioritizing kidney health in their agenda, amidst a lot of competing demands. And Nick, I'll start with you. I know you had your good ROI case.
Well, the issue is that patients, when they attend health centers, they're not interested in coming to some vertical program that's working on one thing or another. They come in with symptoms, and therefore they need to be treated. And so my first pitch would be to say, you're not doing anyone any favors if you include just this, but you don't exclude that. And that's where the whole issue of packages of health services, universal health coverage, but also when it comes to the prevention. So one of the things I think is so important is that we are trying to align and integrate what we're trying to do as a community. And I would say that so for the UN system, but for governments and for civil society. Let's all come together and talk as one, and when we have our multi-sectoral plans, let them sing to us as a group rather than individual disease-specific or risk factors area. And then we can all come into the tent, and I think that's to some extent what people are trying to do, maybe some would say unsuccessfully with the political declaration, but it's trying to say, how do we manage to both integrate and bring everyone in, but still also have some focus to it, and that's where I think the real challenge is.
Yeah, great. Dr. Cressida?
That Nick said the integration is important. So in Thailand, we try to use a team-based approach and integration to treat the patient from the earliest to the final end state. And with the help of health volunteer to educate the patient in community, and with the in health program, we provide screening, education, treatment, both diabetes and kidney disease. So it's like a seamless care for the origin of the patient that have diabetes, hypertension, or some case of the gout, or some case that risk for the kidney disease. So if we use the integrated care program, and we have a policy to advocate a lifestyle modification program to prevent the patient from pre-diabetes to diabetes, so it will reduce the burden of the CKD.
Thank you. Richard?
Yes, building on what I talked about earlier, and let me say this, what we're talking about here is access to resources, and we're talking about costs. Let's be real about that. And it's hard to get the concept across that prevention is going to help minimize your costs. You quoted a number earlier. If you, for every dollar of prevention, you save $45 of cost. I haven't mentioned the human suffering that occurs because of that, but we talk in terms of dollars, so I understand that. And again, important to make that initial investment. We have to make the investment with our primary care physicians, because since I've been dealing with this since 2008 or 2006 after I had my transplant, you know, this siloed approach in healthcare, it's just simply limited, and it's basically, I'm going to use the term wrong. We need to look at the patient as a whole. I know too many patients who have diabetes, bad, and they have no concept of the damage being done to their kidneys. So we have to do a better job. That's where the education starts. Many patients have no idea what who a nephrologist is. I mean, who knows what a nephron is? So a lot of times I'll speak in English to the patients, well, that's a kidney doctor, and you need to see them. But I have a primary care physician. That's great, but I'm looking at you. You need to talk with a nephrologist. So that's part of the education process, and I will say this, in terms of an action, what we do with the Patient Liaison Advisory Group is exchange information. The American Association of Kidney Patients, we have a global summit that reaches out, I think this past year, to 80 countries. We provide information about the disease, about prevention, about new therapeutics, about what can happen if you get involved, how to advocate. So we cover all of those things, and they're available on websites. ISN has a tremendous website that has a lot of information. AAKP.org has a tremendous website, and it's there, so I think people need to take advantage of that and learn from each other. I've just listened to you guys. You're doing some tremendous things, and I want to say this. You often hear complaints, but patients are certainly appreciative of all that you do. We just need to do more. Thank you.
Rhonda?
Thank you. I think we need to stop looking at kidney disease as a consequence of diabetes and hypertension and see it as a standalone problem that patients face, and educate healthcare providers and patients to look for kidney disease, because a lot of kidney disease occurs outside of diabetes and hypertension. And although we can control and halt the progress of kidney disease by looking at diabetes and hypertension, I think it's a condition that deserves more attention. And certainly from PAHO, that's something that we will assist countries to do.
Great. Yeah, Dr. Guled?
I think translating this commitment into national action, I think, and also implementation of the resolution mainly requires first a political commitment from the governments. As I said, setting on the national priorities, it requires commitment. But for us as Somalia, we have, as a government, committed to integrate the NCD care, especially the kidney health, into the primary health care, where we want to make sure it's part of the framework of essential package of health services that goes all the way to the community level, and also want to expand the early detection and the case management, where we employ the community health workers and train them in a way they can identify the indicators and the disease into the primary care level, and also strengthen the national health information management systems, where we can capture the prevalence and incidence of the NCDs, especially kidney disease. And also as a country, we have succeeded to establish publicly funded dialysis center. So we have committed to expand the public-funded dialysis centers because kidney treatment is expensive cost. It almost cost is almost a high cost for out-of-pocket expenditure for the patient of the kidney disease. So just to relieve that burden, the government have expanded the publicly funded dialysis centers. Now we have more major towns, national dialysis centers, and we are aiming to expand it as we identified, as we laid on the national development plan. Again, also, we're as a government committed to increase the workforce that could able either the primary care level or the secondary level that could able to contribute the advance of kidney health. And a country like Somalia, where resources is scarce, the best approach is to emphasize the preventive measures instead of treatment or interventions, which is expensive quite. So we have set the national guideline for the kidney disease and the NCD care at large, where mainly focus on awareness raising, either or patient-centered or to community level, which mainly raises the awareness of the public on the kidney disease and the NCDs at large. So thank you.
Yeah, thank you. And so I did want to, I have a couple of folks here that we want to hear from in the audience. And so we have Chris Toth, who's the CEO of Vantiv. So if we can get a microphone to him, we would love to kind of hear your thoughts and question. I think there's one in the back.
Thank you. Thank you very much for the opportunity for a few thoughts and comments. I want to acknowledge the panel. Loved all of the points. You know, a couple things stood out to me. One was focus, and the second was around education. And I bring both of these up because Vantiv is a newly formed company, but a company with 70 years of history inside of Baxter. Baxter was the initial inventor of peritoneal dialysis, home dialysis. And just here at the beginning of 2025, we separated as an independent company focused on vital organ therapy with a deeper investment in eye forward to how do we improve kidney health and kidney care. And so very specifically, the question or the fire starter comment I was hoping to put forward is really around this idea of what do we do when a patient needs dialysis? I very much agree with all the points of how can we do a better job of slowing progression, manage, provide the education. But, you know, Richard, hearing your comment of crashing into dialysis, thinking about getting referred in at CKD4, these are very scary moments. And we have a basic principle at Vantiv, which is we need to do our jobs as if the patient is our mother, father, brother, sister, or child. And we have around 23,000 employees globally, about 1 million touch points per day. And we just recently announced that over the next 5 years, we're going to invest $1 billion in innovation, education, and partnership to drive better home dialysis programs. So to this end, Dr. Krasada, I was so impressed with what Thailand has done with a PD-first policy. I'd love if you could share some of the things that went well to help educate us all and some of the things that could have been better.
Great, thank you. Yeah, do you want to address that?
Yeah, we're so proud about PD first right now, but we have to change to the patient choice policy, right? Baxter here have a main contributor for some PD first policy. Actually, we now launch 77.2 million people know kidney health by with the help of some private sector to give the people some micro dipstick. So I think the non-health sector, especially private sector, will help a lot about to improve the kidney health. Many companies work with us to build a better kidney health better. And what is your question? Is actually the Thailand have a patient association that we call Kidney Friend Association. Okay, they work with the government official to set a policy, including the PD first policy. And now we try to change from the expensive modality that in between PD first policy and patient choice policy that we call, what does it call, Dr. Orathai? Between the PD first and like a machine. We use a machine for a while, but I think that policy is not work because it's too expensive for government and for the people. Even the cost of the expenditure, the universal health care is a cover up all, but it cannot last for many years if that policy still persists. So now we have to change to the patient choice policy, that you can choose a PD or you can choose another method. It's up to patient decision with doctor and healthcare professional.
Thank you. And we also had someone else in the audience, Professor Hugh Brady, President of Imperial College London, that we'd love to hear from. Right there.
Maybe I'll stand rather than have my back to everybody. Good morning, everybody. I've been asked to, I suppose, offer a few reflections, not because probably I'm president of Imperial College London, and I've been university president of 3 different universities for the last 20 years, but because before that, I was for 20 years a card-carrying nephrologist and a card-carrying member of the International Society of Nephrology. But I should reassure you, my wife is a nephrologist, so there are journals scattered around our living room, so I'm still very much living the specialty. Just thinking about it though, nephrology over its history has really probably been a game of two halves. You had incredibly brave innovation and risk-taking in the 40s, 50s, and 60s. I spent 10 years of my life in the Brigham and Women's Hospital in Boston and met actually Joe Murray, won the Nobel Prize for renal transplantation, for the pioneering work in that. Remember, he was a plastic surgeon. So you had that generation who were the pioneers in renal transplantation and hemodialysis and peritoneal dialysis. Brave risk takers, but all of that work was really 50s and 60s. And whereas there's been a lot of progress over the next 70 years, we have to be honest that it has been very, very slow. So I'd like to talk about another way maybe that the resolutions, political resolutions and declarations can really help the cause. Because we've talked about the impact on clinical care, public health, population health. We've talked about education. Well, I suppose I'd like to make a pitch that we can use the profile that resolutions and declarations give us to up the ante and up the funding when it comes to research. And that is really, really important. So just to give you 3 areas as an example. If you take the technology underpinning dialysis, and it's fantastic to hear the investments that are taking place, but certainly in my world, if you take Imperial College London, one of the world's great STEM and business universities, very few of the brightest minds in engineering and technology are looking into the technology that will make dialysis more affordable, more efficient, more accessible, and more transportable. So declarations like this can help us attract the brightest and best young minds in the world back into the field. to address this really important issue. The second, I would say, is around understanding the molecular drivers. So what are the triggers that actually start your kidneys on that really rocky road down, ultimately, in so many patients towards failure? It's relatively easy in communicable diseases. You know, the bug, starts the cascade. But actually, if you look over the last 20, 30 years, where there has been some progress, we have made, relative to cancer or communicable diseases, very little progress identifying the specific molecules that activate the disease, causes progression, and that we can target with new drug therapies. Now, that is probably about to change, because we can now couple the huge databases that we have from genomics, proteomics, metabolomics with the AI revolution. So again, declarations and political profiles can really put the pressure on research funders, can really excite philanthropists, so that they're now investing in research in the area at a really opportune moment. The third thing I would just say is the holy grail, of course, is prevention, or if not prevention, at least early detection, so that we can intervene early. Again, one of the problems is that the business model really doesn't work in a way for diagnostics in the same way as it works for therapeutics. It's very difficult to attract, or more difficult to attract, biotechnologists or indeed venture capital to invest in diagnostics, because the potential returns are so much bigger when it comes to therapeutics. But it's absolutely essential, if we're to get ahead of the game, that we find ways of developing a new model that attracts the funding to develop diagnostics so we can get in there early. That is most likely going to take new forms of partnership and new forms of pressure between public funding, public research funding, philanthropists, and the pressure, for example, that can come from patient organizations. But if you take the really big problems, problematic diseases, so chronic non-communicable diseases, or indeed in the world of infectious disease, if you take antimicrobial resistance, the challenge with both is that the business model doesn't work. And that challenges us to come up with new models that will attract the investment. So just 3 reflections from a former but very interested nephrologist.
Thank you so much, Professor. I've heard a lot around prevention, integration, innovation as real keys. Marcello, I wanted to see if you have any closing thoughts or remarks before we wrap up today's discussion, some key takeaways.
Well, I think we've had a really great discussion. I really enjoyed hearing from all the panelists. We've heard about why does kidney health matter? We've heard about some compelling opportunities for countries to invest, whether that's in universal healthcare, including kidney-relevant drugs and diagnostics, whether it's scaling early detection programs, eliminating those silos that change the patient experience and worsen the clinical outcomes. And then we close with 2, I thought, really interesting reflections on potential partnerships. Partnerships with industry that are going to be critical for this next wave of implementation. And as an academic myself, very interested to hear about the opportunities for academic partnership, both on the diagnostics and the therapeutic side with exciting new technologies. So those are what I leave this session with. Coming back to the conversation with Dr. Schwarz, there's lots to do, and we're going to call on our friends in the International Diabetes Federation to help with that, but with a great sense of optimism. And I'd like to thank all of you for being here today, and I'd like to thank those of us who joined us online. I wish all of you the really exciting and enjoyable General Assembly, and I'm going to pass back to Kate. Thanks.
Yes, and thank you to ISN for partnering with us to be able to bring this important conversation here.